Hey, good evening, everyone. My name is Sharon Chen. I'm an ID physician and clinical microbiologist in Sydney, in Australia. Welcome to the next episode of Fungal Frontiers in the Pacific. And this was something that ANZMIC, which is the Australian Society for Mycology, Australian and New Zealand Society for Mycology, and the Asian Fungal Working Group of ISHAM partnered to provide webinars in a time-friendly zone, as it was sometimes difficult to wake up and attend the webinars put on by the ECMM or indeed the MSG ERC. And today's session is entitled When Infection Defies Expectations. We have these webinars every 4 months or so. So on behalf of my co-chair, Professor Tan van Hock, I'd like to open tonight's webinar, and I'll hand over it to him to introduce the speakers and the case presenters.
Thank you, Sharon, and thanks everyone for joining us this evening. So today, the case will be presented by Dr. Vongsakorn Limvongsakorn, who is from Sriraj Hospital, Mahidol University in Bangkok. And to discuss the case, we have three very experienced infectious disease physicians. So from India, we have Dr. Atul Patel from Ahmedabad. From Singapore, my good friend and colleague, Dr. Thuan Tong, who works primarily in the field of transplant ID and infections in the immunocompromised host, and Dr. Natalie Davidson, who is an infectious disease physician and microbiologist from Queensland. Sharon?
Yes. So I think we will start off with Dr. Vongsakorn's presentation, followed by discussion, and the panelists will be inputting into the key points of this case. So let's kick off. And Dr. Vongsakorn, if I could invite you to put your slides up.
Okay.
Yes, for the audience, please feel free to key in questions into the Q&A anytime. Okay, Vongsakorn.
Okay, share to the slide for the presentations. Okay, thank you, professors. I'm sharing my screen now, and good evening to the panelists and everyone. My name, I'm Dr. Vongsakorn Limvongsakorn from Sriraj Hospital in Thailand. Today, I would like to represent interesting case entitled A Gentleman with Mysterious Paraspinal Abscess. The patient is a 66-year-old Thai man, a farmer from Srisaket province in the northeastern Thailand with no known prior comorbidity. He was presented with a back pain for 1 week. 4 months ago, he presented with a low-grade fever, productive cough with increased sputum production, and a progressive dyspnea, and a weight loss of 9 kilograms over 2 months period. And the check X-ray in that time is show reticular and patchy infiltration at the left lower lung zone and the small left pleural effusion. Initial sputum investigation culture for bacteria show microbiota and the FP, PCR, NGM were negative. He proceeded to the CT chest. CT chest show patchy infiltrate at the left lower lung area and the reticulonodular infiltration in the left lower lung, and multiple intra-abdominal and intra-mesenteric lymphadenopathy. And EBUS with TBNA was performed. Initial smear PCR and the mycobacteria were negative. And the mycobacterium culture identified Mycobacterium colombiensis is a slow-grower non-tuberculous mycobacteria. In that time, he was diagnosed pulmonary Mycobacterium colombiensis infections and treated with the initial regimen of amikacin, azithromycin, and levofloxacin for the 2 weeks, and followed by maintenance course of the antibiotic azithromycin, rifampicin, and ethambutol and 2 pieces. Over the next 3 months, his clinical course showed significant improvements. He became affected by and the respiratory symptom and imaging resolved well. Chest X-ray after 3 months of the treatment were improvements of the chest X-ray. However, 1 week ago, he acutely presented with high-grade fever and progressive severe midline back pain with no radiation, no neurological deficits. And the physical examination is show cord cavitation, both lung and the tender at right paraspinal area around T11 to T12 level. And investigation show the normocytic anemia and the marked leukocytosis, cholestasis, pattern of the liver enzyme, found hypoalbuminemia, and the mark of hyperglobulinemia. And the chest X-ray show progressive bilateral alveolar infiltrate both lung. And he proceed to the CT thoracic lumbar spine with a contact. CT was show focal osteoarthritic lesion at the spinal process and light lamina of T11 along with light paraspinal fluid collection from the T10 to the T12. In summary, our clinical problem list include a 66-year-old man with a history of pulmonary Mycobacterium colombiensis infection, with currently receiving azithromycin, rifampicin, and ethambutol. He was present with acute high-grade fever with a worsening dyspnea and cough. T11 vertebral spondylolisthesis with a paraspinal abscess and hematological and cholestasis liver enzyme abnormality. At this point, I would like to invite our panelists to discuss what are the potential etiology and the likely pathogen in this acute presentation.
It's Sharon speaking. I guess a diagnostic procedure will need to be performed, but before we do that, perhaps Professor Patel, would you have any thoughts about how we might get to the diagnosis in this gentleman?
Yeah. So I think this is a very interesting case presented to us. The initial diagnosis of NTM lung disease, I think we need to rethink about the diagnosis. The reason is that the patient has only one sample, respiratory sample, which showed or which grew the non-tuberculous mycobacteria. This is number one. And patient is a farmer, so it's very likely that he's exposed to the NTM species into the farm. But I think we need at least two different respiratory samples growing the same thing unless there is a BAL sample. I probably miss whether it was a BAL sample or it was a sputum. So this is number one. And the second thing, the patient has a very high the globulin level. So that requires further investigation. So I would like to know what is the erythrocyte sedimentation rate. If it is very high, like more than 100, then I think we should look for the paraproteinemias. So that is the multiple myeloma and other the paraproteinemia. Then second is the autoimmune conditions like lupus. The third could be, it's not, I mean, it cannot give you the very high the globulin levels, but the patient who has a chronic liver disease, they may have the reverse the globulin and the albumin globulin ratio. So I think we should do some additional hematological workup, look for some autoimmune conditions. And also, I think revisit the diagnosis of NTM lung disease, because after initial the response, and we do not know the drug susceptibility also. So what for this the non-prescribed. So I think we should also look for this. And looks like there is a disease progression. So patient has primary pulmonary infection, which has progressed into the lungs as well as into the paraspinal region, producing vertebrodiscitis.
Okay, so we're working on a one pathogen hypothesis. Dr. Vongsakorn, could you oblige us with the ESR and the rest of the autoimmune screen if this patient had these tests? Dr. Vongsakorn?
Did the patient have an
No,
ESR?
no lab, no ESR
No,
setting for the lab. Yes, no lab.
And he didn't have any autoimmune serology done, or his ANAs and that sort of thing?
No sent to the ANA or autoimmune profiles. No sent to the anti-HAV. Yes.
Okay. All right. Van Hock, over to you.
Oh, yeah. So maybe I should ask Dr. Davidson for her thoughts on what this could be, if not Mycobacterium colombiense.
Yeah, thanks very much, and thanks for the great case. I agree with what Dr. Patel has said. I don't think we have enough evidence to say that this patient has an NTM infection, though in saying that, we can't obviously rule it out at this stage. So I think what is going through my mind at the moment is, could this be an NTM infection with progression? Or is there more than one thing at play? For example, if this patient did have an NTM infection, have they now subsequently got a secondary infection with either, a mycobacteria or another bacterial pathogen or a fungal pathogen? I think the differential is still quite broad from that perspective. And if they do have more than one infection at play, I agree with what Dr. Patel has said as well. We probably need to think of whether there is something underlying making this patient more susceptible to infection in this setting. So I think from my perspective, the differential is still broad. And as Sharon has mentioned, I think we need some more investigations.
Thank
Okay.
you. Thank you. Thuan Tong, would you like to say anything? Hazard some guesses or suggest a way forward?
Thank you, Van Hock and Sharon and all. It is a very interesting case. First, this is a Thai farmer, right? So it does it does make me think about possibilities in terms of exposure and so on, right? Some things are a little bit more common. Also interesting that this got Mycobacter. I'm not most familiar with Columbiaceae, but I imagine that if you are Thai and you have a disseminated process like NTM, we also need to invoke thinking about all these gamma interferon antibodies kind of situations. Although this guy is a male, I did remember that we say he had loss of weight, something like what, 9 kilograms, and the lesion was mass-like or condensed consolidation, if I recall correctly, on scan 5 by 3 centimeters. So it feels like, well, first the NTM, as what Dr. Patel say, one sample may be difficult to interpret, but then is this just NTM? It seems to be a very disseminated process in that there are lymph adenopathy, and then it has progressed. So we are not dealing with one entity. If it is one entity, it's a complex entity. And then this being a fungal symposium, I think fungus in Thailand, really, we need to think about those things. And I imagine Thailand will have all the usual fungus that we all have, the candidas, the cryptococcus, the aspergillus, but the farmer, they're quite a hardy lot. So I imagine it's something the farmer has been exposed to, and then that will be more endemic stuff. And I suppose things like Thalassemia and all that. But again, they are exposed to all these things, dissemination, weight loss. That's could ring a bell, but that's just my thoughts at this point in time. Over, Pan Hock.
Yeah, thank you. Well, Dr. Vongsakorn, did your team consider the possibility of myeloidosis? This patient is from northeastern Thailand. He has a left lower lip consolidation, and then now he has a high-grade fever with a white cell count of 28,000. I mean, quite apart from the fact that we are in a fungal webinar.
Yeah, myeloid would be quite a real possibility.
Dr. Vongsakorn?
Yes, and I'm concerned to the myeloidosis and the fungal in the infection in these patients. And thank you very much for all excellent comments. Now, allow me to share to the definite investigation, the result in this case. In this case, is performed to the percutaneous drainage of the paravertebral abscess. Was a cam stain was shown is what is a pathogen in this cam stain in the oil field of microscopy. Yes.
Okay, someone like to hazard a guess? I think we should be offering prizes for the correct answers. I'll write that down, and maybe next time. Kind of looks intracellular.
Yeah. Dr. Natalie, would you like to hazard a guess?
Yes, I mean, I agree that it looks like some intracellular forms and some yeast forms, and particularly that picture on the right, it looks like there might be some internal septation, which could be a distinguishing feature for Phalaromyces. But the differential is still broad. I would also consider histoplasma. I'll hand over to my other panelists to see if they have any additional comments.
Atul, you have any comments?
So the picture on the right, I mean, shows a distinct septae. So I think Phalaromyces is number one for the diagnosis over here.
Okay.
Yeah, thank you, Professor. In the culture is the cam stain is show small oval yeast with a characteristic of a clear central septum, and subsequently of the fungal culture you is a colony producing late diffusible pigments which did not go in the cycloheximides. This led to the definite identification of the Thalassemia magnifica. Yes, and given to the coexistence of the two unusual opportunistic infection, Mycobacterium colombiensis and the Thalassemia magnifica in the HIV negative patients, further investigate the host immune status, the anti-interferon gamma autoantibody test was strongly positive with a high optical density value. And consequently, the final diagnosis were established disseminated thalomycosis involving the spine and the lung, pulmonary Mycobacterium columbiensis infections, and the anti-interferon gamma autoantibody syndrome. Regarding his management, the patient received amphotericin B deoxycholate, which was subsequently transitioned to the liposomal amphotericin B for a total 2 weeks and followed by maintenance oral itaconazole. For NTM infection, we continue azithromycin, ethambutol, and levofloxacin. Rifampicin was discontinued due to significant drug interaction with itaconazole. Following this targeted therapy, the patient showed marked clinical improvements with a complete resolution with a fever, less belly symptom, and back pain. In the conclusion, the highlight this case clinical correlation between host immunity and the opportunistic pathogen. It demonstrates a classic of the presentation of the disseminated thalomycosis causing bone and soft tissue infection in the patient with adult onset immunodeficiency, especially anti-interferon gamma autoantibody syndrome. This underlying disease conditions should be highly suspected in the Southeast Asia patient who were presented with a multiple or atypical opportunistic infection despite being HIV negative. Thank you very much for your attention. Yes.
Thank you, Dr. Vongsakorn. Before we go to general questions, and I have one in relation to this case, Dr. Patel has his hand up.
I have also one question.
No, Bibi, please.
So thank you. Thank you for a very interesting case. So I have, at least in, 2 questions. The one is like with the deterioration, like patient has high-grade fever and back pain. The X-ray just showed some the shadows and infiltration. So do you have CT scan at that time with the deterioration? This is number 1. And second, like how do you explain very high globulin level of 8, like generally gives you a hyperviscosity syndrome and the other things. So what was the reason why the patient has very high serum globulin level?
Thank you. Dr. Vongsakorn?
Oh, wow. Sorry, I need to the question again, please. Yes.
Dr. Patel, I think he probably didn't quite get your question. So one of them was the reason for the high globulin levels, Dr. Vongsakorn?
Yes, it's a high level. It's a globulin in the liver test. It's really high. At the first presentation, Mycobacterium columbiensis and the leukocytosis and the hyperglobulinemia at the previous infection. Yes, and work up to the anti-interferon in this infection in the thalomycosis.
Yeah, in the chat, one of the attendees has suggested that the low albumin and the high globulin can be due to a prolonged state of catabolism and infection. So the infection itself. What do you think about that?
Yeah, I think the infection, like it's a 3-4 months duration of infection. I don't expect that globulin should be very high. 8 gram of globulin is very high. So I think we should do a protein electrophoresis or immunofixation just to find out like whether it is a polyclonal or it is a monoclonal hypergamma globulinemia. So I think that hematological workup is probably required for this patient.
Well, we're now forewarned, so that's great. Dr. Vongsakorn, did you want to comment any more on the case?
Yes, I think I found opportunistic infection in the CMI defect, such as NTM infection and the fungal infection, such as thalomycosis or cryptococcosis in the setting. Elderly in the lab show leukocytosis and hypercopolynemia. I think to the concern to the host immune status in the interferon gamma autoimmune antibody for show the prone to the opportunistic infection. Well, yes, I think to the take-home message. Yes.
Yeah. Just to clarify, where was the Mycobacterium colombiense isolated from initially? What specimen? Deep lung?
Yes, deep lung, bronchoalveolar lavage. Yes.
Okay. And just once or more than once?
In one bronchoalveolar lavage and one sputum culture for mycobacteria.
All right. Okay. All right. Hock, over to you. I think we've kind of the case is done.
Yes, thank you. So thank you very much, Dr. Vongsakorn. That's really a very interesting case, quite illuminating also. Now we will do the topic presentations, and we actually have two presenters. We will start with Dr. Kawisara Krasaewes, who is from Chiang Mai University. Following that, we have Dr. Lottie Brown. Yeah, so I think we will start with Dr. Kawisara, please.
Yes. Hello, everyone from Thailand. So today it is very great honor that I have a talk on this topic. So today I'm going to talk about the interferon gamma autoantibodies and emerging driver of thalomycosis and other fungal disease. So let's start. Okay. So outlines today gonna be two things. First is what is the interferon gamma autoantibodies and what are the infections in those patients. Let's start with the immune pathway. The one we should understand is the interferon gamma and IL-12 axis. This axis is a fundamental bidirectional communication loop between innate and adaptive immune system. Its primary role is coordinate protective immunity against intracellular pathogens such as mycobacteria, Thalomycepae, and also Salmonella and certain viruses. Start with the macrophage and phagocyte ingest this pathogen and secrete the IL-12. Then IL-12 stimulate NK cell and T helper 1 cell to produce interferon gamma here, which is a main actor now. Interferon gamma bind back to the macrophage and then hyperactivating them to kill the pathogen inside the macrophage and release even more IL-12. This continual loop magnifies the immune response until the infection is clear. So what happened if our body had an interferon gamma autoantibodies? The interferon gamma autoantibodies are self-targeted immune protein that mistakenly bind to and block the interferon gamma, causing the disease and interferon gamma autoantibody syndrome, or some people say adult onset immune deficiency syndrome. This syndrome makes previously healthy adults become highly susceptible to severe recurrent opportunistic infection, mimicking an advanced HIV/AIDS or some genetic immune defect. So we found a first case of anti-interferon gamma autoantibodies in the 2004 in a Filipino patient who died with a severe mycobacterial infection. And then in 2012, there were reported cases in Thailand and Taiwan. Since that time, number of cases and also studies have been documented. The prevalence of the disease is prominently observed in the Asian region, such as Southern China, Taiwan, Thailand, and also Japan. And scattered cases have been documented in non-Asian as well, such as United Kingdom, US, and Germany. Since 2004, they identified 1,430 global cases of anti-interferon gamma autoantibodies were reported. Let's see the epidemiology of this syndrome. The median age at the diagnosis is approximately 55 years. There was no significant gender difference. The prevalence of this disease is like high, eventually, especially in the HIV patient, HIV negative disseminated chylomicrosis infection patient. So this could be one of the clues to suspect those disease in these patients. This disease has a long-term cause. Some people like a persistent more than a year or 2 years. And due to immune deficiency, this disease is often combined with the recurrent, persistent of the opportunistic infection, so leading to a poor prognosis in patient in this group. The initial clinical sign and symptom of the anti-interferon gamma autoantibodies mainly from the opportunistic infection, like in our case. Common clinical manifestation include unexplained fever, cachexia, cough, bone pain. Overall of this syndrome can affect, actually they can affect various of the organ, including the lymph node, lung, skin, bone and joint, and some people have involved in the bone marrow as well, the blood, and also liver and spleen. Disseminated opportunistic infection frequently serve as the initial diagnostic clue for this syndrome. And the disease is commonly associated with at least 1 or 2 opportunistic infection. We found that the NTM and the Thalomyces malafii is the most common opportunistic pathogen in patient in this group. About the NTM, so common species of NTM are Mycobacterium abscessus and Mycobacterium avium complex. From our own data from the Chiang Mai University Hospital, Dr. Romani and Dr. Thapanot conduct a retrospective study in here, and from 1st January 2012 till 31st December 2021. So at that period, we have a total 135 patients with the anti-interferon gamma autoantibody. The median age of the patient is around 56 years, which is concordant with other studies. Common clinical presentations at that time were fever, 90%, and lymphadenopathy around 80%. Half of these patients had a skin lesion as well. Number of the infection sites were 2, and the recurrence rate is quite high, which is 45%. Most common opportunistic infection in our cohort, the first one is NTM infection, Salmonella infection, Mycobacterium tuberculosis, and Thalomyces infection. So we're going to focus on the Thalomyces infection in the interferon gamma autoantibody syndrome. From 1960 to 2022, or over 288,000 thalomycosis cases has been reported in 34 countries. But area where the thalomycosis is endemic have expanded from the southern China, Southeast Asia, which is Thailand as well, and also northeast of the India. The transmission of thalomycosis is reported to be affected by soil exposure. Thalomycosis is no longer a disease associated with the AIDS, although it has a high distribution level in HIV positive patients, which is almost 90%. But nowadays, they are increasing of the T. malafii infection rate among HIV uninfected, but immunocompromised patients around 10% here. Because the situation is also associated with the expansion or utilization of the potent immunosuppressive drug in the transplant recipient autoimmune disease, and also in our patient, which is autointerferon gamma autoantibodies. The T. malafii infection in patient with autointerferon gamma autoantibody usually manifests as a fever of unknown origin and lymphadenopathy. Occasionally, T-manifest infection might precipitate the development of the reactive skin disease as well. For example, Sweet syndrome, erythema donosum, exanthematous pustulosis, and also pustula psoriasis. And sometimes they can cause a direct infection of the cutaneous region as well. As I mentioned before, tuberculomycosis is increasingly reported in autointerferon gamma autoantibody syndrome in endemic area. Therefore, I and Dr. Romani, we did a study in Chiang Mai University to compare characteristic and mortality between patient IgA syndrome and with the patient HIV. So a retrospective cohort study was conducted at our Maharanakhon Chiang Mai Hospital in Chiang Mai, Thailand. Patient aged more than 18 years old with a tuberculomycosis and documentation of HIV infection or detection of anti-interferon gamma autoantibody were included in the study. During the study of period, which is the 1st January 2012 till 30 June 2021, we have a total like a 32 anti-interferon gamma and autoantibody syndrome with the tuberculomycosis, and 235 people living with HIV diagnosed with the tuberculomycosis were included in the analysis. So let's see the result. The demographic characteristics show that the patient with anti-interferon gamma autoantibody had a median age of 57.5 years, and people living with HIV has a median age of 35 years. You will see that the patient with interferon gamma autoantibody were more likely to be older and have a more underlying disease compared to the patient with HIV/AIDS. Next, people living with HIV/AIDS were more likely to have a tuberculomycosis as a first opportunistic infection, and sometimes in patient in this group they also have other opportunistic infection as well. For example, it's a candida, and also PCP is quite common in patient in this group. Whereas patients with the anti-interferon gamma autoantibody were more likely to have tuberculosis, NTM infection, and some other infections as a concurrent opportunistic infection. Constitutional symptoms, including fever, fatigue, weight loss, and anorexia. Actually, we found in both populations, but in our cohort more commonly in the people living with HIV/AIDS. Lymphadenopathy and bone and joint infection were more commonly found in the patient with autointerferon gamma autoantibodies here. About the skin lesion commonly seen in the patient with anti-interferon gamma autoantibody were more diverse, include macule, patch, papule plaque, and nodule and abscess, and Sweet syndrome, which is a reactive skin disease. Whereas the HIV patient, they were more likely to have a central umbilicated papule. From the laboratory findings, we found patients with interferon gamma autoantibodies more frequently had a higher white blood cell, eosinophil, and also platelet count. About the liver function, we found that they have like a higher alkali phosphatase as well, but less fungemia compared to the people living with HIV. Shed X-ray. Alveolar infiltration and pleural effusion were commonly found in the patient with anti-interferon gamma autoantibodies, whereas interstitial infiltration was common in the people living with HIV/AIDS. The probability of death is shown. We found 24-week mortality was 9.4% in patients with autoantibody interferon gamma autoantibody, and 15.3% in the people living with HIV. The mortality rate was not statistically different. So actually they have a few reports of the tuberculomycosis, specifically in the patient with autointerferon gamma autoantibodies. The detail of the study conducted by our team is here in the first column. from the Gao et al. In the middle column, and then from the Chen et al. In the third column are summarized as shown. A common finding across these three studies is that the median age of the patients was over 50, which is quite old. Then with the majority presenting with the fever, weight loss, and lymphadenopathy. The prevalence of skin lesion is quite vary between the study, and mortality rate is ranking from 9% to 24%. So take home message from my talk and also from our case. And interferon gamma autoantibodies is reported to be most prevalent in China and Southeast Asia, including Thailand, which is an area where the TMNFI is endemic. Tuberculomycosis has been reported to occur in those patients alongside other disseminated infections, such as NTM, which is the most common. The clinical feature of a tuberculomycosis in patients with anti-interferon gamma autoantibody have differ in some aspect from the people living with HIV/AIDS. Awareness of tuberculomycosis in patients with an interferon gamma autoantibodies in the endemic area should be considered. Thank you for your attention.
Thank you very much, Dr. Krasaewes. So let's go on with the next presentation, and then we'll do all the questions towards the end of this webinar. So our next speaker deserves a very big thank you. She joins us from a different time zone, actually. Dr. Lottie Brown is Academic Fellow at the Institute of Microbiology and Infectious Diseases, City St. George's at the University of London. So thank you very much, Dr. Brown. We all look forward to your talk.
Thank you so much for the kind introduction. I'm actually not in the UK at the moment. I'm in Japan at another conference, but I'm really happy to join you from here. I'm based in the UK in London, but I have done some fellowships in Vietnam at the Tropical Medicine Research Centre for tuberculomycosis in Ho Chi Minh City. This is a dedicated research unit funded by the NIH and led by Professor Thuy Le. And I'm very excited because I've just found out that I've got welcome funding to move to Vietnam full-time from September to do my clinical PhD fellowship. In the next 30 minutes, I will provide a brief overview of tuberculomycosis epidemiology, ecology, and we've already heard a lot about the clinical presentations, but I'll talk a little bit more about the clinical presentation in patients with advanced HIV disease. I'll then discuss the major diagnostic and treatment challenges and the recent exciting innovations and advances that have been made to address these. And I'll just say it's an extremely rewarding, fast-moving field to become involved in. So it's been great for myself. So we know that tuberculomycosis is caused by Talaromyces monophyly. This is a thermally dimorphic fungus. That means it can switch from an environmental mold to a pathogenic yeast at human body temperature. And in these dark purple regions on the map, it's actually a leading opportunistic infection among people with advanced HIV disease, with hospital admissions and deaths surpassing those from other major killers like cryptococcal meningitis, and in some regions nearly rivaling those of tuberculosis. Historically, unfortunately, this has been a very neglected disease that's received very little programmatic attention and resources. But I'm glad to say that things are changing. So in 2022, the WHO named Talaromyces monophyly a fungal priority pathogen. And I think this was a really important step to generating research and interest in Talaromyces. The respiratory system is the primary portal of entry for Talaromyces monophyly. Once inside the lung, it's rapidly phagocytosed by alveolar macrophages. And in immunocompromised people, it survives within the macrophages to disseminate via the reticuloendothelial system to cause multi-system infection with tropism for the liver, spleen, bone marrow, and skin. And what we then see is spillover from infected tissues to the blood, leading to secondary hematogenous spread. So although the area of endemicity is restricted to South and Southeast Asia, we can see that this region encompasses half of the world's population. So there's huge potential for this fungus to take hold. Our best estimates of disease burden are a little bit old now, so 5 years. In a systematic review, it was estimated that there was 25,000 cases per year. But these were based on culture-proven infections, which will undoubtedly underestimate the true burden of disease because of the poor sensitivity of culture for detecting this fungus. The incidence of talaromycosis is projected to rise, and that's because of, as we've heard, this expanding population of immunocompromised people, as well as climate change. This systematic review in 2020 looked at talaromycosis prevalence according to country, and they looked at the prevalence in people with HIV of any stage. So it included patients with well-controlled HIV who are much less likely to develop talaromycosis. But what they found is that the highest prevalence was in Vietnam at 6.4%, followed by Thailand, China, and then India. But what was really interesting is that there were huge ranges within each country. So for example, in China, in northern China, the prevalence was less than 1%, whereas there were certain cohorts in southern China where the prevalence exceeded 25%. So clearly there's some hotspots even within countries. Zooming in now to the epidemiology in Vietnam, this prospective cohort study screened patients with advanced HIV disease, defined as a CD4 less than 100, and any symptoms, including patients who were asymptomatic. And what was found is that 1 in 5 had culture-proven talaromycosis, which is just huge. The number nearly matched cases of disseminated TB and far surpassed cryptococcal disease, histoplasmosis, and NTM. So possibly, a disease which is going undetected, but when we are screening for it, we're unveiling a huge prevalence. I think the ecology of talaromycosis is a really interesting area. So we tried to depict it here. This is a figure created by Professor Lei's daughter, Tung Vi, who is an excellent artist. And what she's showing is that the bamboo rat, we've known for many years, serves as a zoonotic reservoir for this disease. Bamboo rats are these very large mammals that can grow up to 0.5 meter long, which I think is a terrifying thought. And they are found in the highland areas of Southeast Asia. They form these extensive burrow systems around bamboo and other tropical plant crops. And they're regarded as agricultural pests, but they're also farmed and eaten as meat in some areas. And fungus has repeatedly been isolated in bamboo rat organs, as well as in the stool and the soil around their burrows. There's no epidemiological evidence of direct bamboo rat to human transmission. Rather, kind of what's hypothesized is that it's exposure to the soil associated with the bamboo rats that is the primary driving factor for acquiring talaromycosis. What we also know is that during the high temperatures, humidity, and rainfall of the tropical monsoon season, the incidence of talaromycosis rises from 30 to 73%, so more than doubles. Before last year, there was only one case control study that was ever done for talaromycosis investigating risk factors. And that was done way back in the 90s in Thailand, in Chiang Mai. We conducted the first case control study in Vietnam. This was a multi-center matched case control study, recruiting participants with advanced HIV disease from the inpatient and outpatient departments of 2 major hospitals in North and South Vietnam, which receive about 40% of national inpatient HIV referrals in the country. We matched cases and controls by age, sex, and CD4. And our controls were clinically relevant patients who were diagnosed with a range of other opportunistic infections. In our multivariable analysis, we found that exposure to tropical plants, rice, bamboo, and sugarcane, and to farm animals, including cattle, swine, and poultry, gave a twofold higher odds for developing talaromycosis. And this is consistent with the results of the prior case control study done way back in the 90s. Where our two studies differed was that exposure to soil was not a risk factor for developing talaromycosis in our work. And what we concluded is that it's probably exposure to a very specific type of soil that's enriched with decaying tropical plant substrate and an animal excreta that's preferred by Talaromyces marnifae. We also did geographical mapping, which was really informative. So we found that talaromycosis cases were 8 to 10 times higher in the highlands compared to the lowlands. Further interrogation of those patients living in the lowlands who developed talaromycosis revealed that previous residence or travel to the highland regions at any point in their life increased the odds of developing talaromycosis threefold. So in that way, we were able to demonstrate the first epidemiological link between human talaromycosis and residence or travel to highland regions in this highly endemic setting of Vietnam. And I thought our findings also offered some insights, potential insights into disease latency and the natural history of this disease. So we think that Talaromyces marnifae probably causes an acute respiratory tract infection in immunocompetent people, possibly comparable to blastomycosis in the US, but it's an area that needs more investigation. There's a hypothesis that the formation of lung granulomas on exposure to Talaromyces marnifae may allow the persistence of this fungus and the opportunity for it to reactivate later if the patient becomes immunocompromised. The manifestations of talaromycosis vary significantly according to host immunity. And we've heard a lot about the HIV negative patients today, so I won't dwell on this too much, but what really strikes me about these is that we see these very atypical localized lesions sometimes in the bones and joints, like the fantastic case that we heard today, but also possibly in the gastrointestinal or urogenital tract. And this is in contrast to patients with advanced HIV disease, who often first present with disseminated infection, skin lesions, constitutional symptoms. The HIV negative patients consist of a very broad range of underlying conditions. The key thing is that they're all less likely to develop typical skin lesions. And as we heard, they're significantly less likely to have positive blood culture. And for that reason, as well as their atypical presentation, they're really tricky to diagnose, and diagnosis is often severely delayed with, unfortunately, a high mortality. And really, we've seen this shift in the epidemiology of talaromycosis, where it was considered primarily a disease of advanced HIV disease, but is now emerging amongst other groups of immunocompromised patients who are HIV negative. And there's new risk factors being identified all the time. In people with advanced HIV disease, the clinical features are very non-specific and they overlap with other opportunistic infections. So skin lesions, pictured here, are the most specific sign, but they are absent in about 30% of patients with advanced HIV disease. And it's typically a sign of very late advanced infection. So it's not a good kind of diagnostic clinical sign, because by the time you're seeing skin lesions, they already have advanced stage infection, and that's when treatment is less likely to be effective. There's also kind of significant overlap. So it may be that they're very difficult to differentiate from skin lesions of histoplasmosis and cryptococcus. And for that reason, the initiation of empirical therapy is not recommended. We'll talk about treatment shortly, but the antifungal toxicity profiles and the drug-drug interactions are one of the reasons why empirical therapy is not recommended, and it's so important to get that diagnosis drilled down. Co-infections are extremely common. We saw in the last talk, 80% of patients with taloromycosis and advanced HIV disease have some kind of co-infection, and that's pretty consistent throughout the literature. And the most common ones are tuberculosis, pneumocystis, pneumonia, and CMV, among many others. But there is, despite this being a non-specific clinical presentation, there are some clues that we can pick up on. So the clue really is to look out for a reticuloendothelial syndrome. This was the same cohort of 900 patients that were screened for taloromycosis in Vietnam. So they're all patients with advanced HIV disease. Comparing taloromycosis to the patients without taloromycosis, the constitutional symptoms, fever, skin lesions were significantly more common, as well as signs of lymphadenopathy and hepatosplenomegaly. And then in the basic blood tests, thrombocytopenia, anemia, and raised AST were prominent among patients with taloromycosis. And that really is representative of the fact that taloromycosis is a reticuloendothelial infection that spreads via the macrophages and then therefore affects the liver and the spleen and the bone marrow. So there's been the diagnosis in almost all settings still relies on culture. The main limitation being that it has a long turnaround time. It's pretty insensitive, so misses 30 to 50% of cases in terms of blood culture. You can culture other clinical specimens like skin lesions or lymph nodes, but that's obviously reliant on lymphadenopathy and skin lesions being present, and often they're not in the early stages of infection. So really the question is about how we can improve early diagnosis. And there's been some fantastic advances made in this area. So specifically in direct methods of pathogen detection with PCR and antigen tests, but also indirect methods of host-based detection now in the early stages of development, including interferon gamma release assays and an IgG assay. Today, I'm going to focus on antigen detection, the reason being that this is where we have seen the most progress, with 2 antigen tests being developed and also now available as point-of-care lateral flow platforms. The first antigen test developed was the monoclonal antibody 4D1, developed in Thailand. This is a highly specific immunoglobulin for detecting a cytoplasmic yeast phase antigen of Taloromyces marnifei, and it's consistently demonstrated excellent specificity, both analytical and clinical specificity. It doesn't seem to cross-react with any other fungal pathogens or mycobacterial pathogens. And in retrospective clinical evaluations, the sensitivity seems to be pretty high, so 89%. So far, it's only been evaluated in Thailand in retrospective evaluations, but it's also been converted into a lateral flow assay platform, which has shown similarly high diagnostic performance. The second antigen test developed was the MP1P EIA. So this targets a fungal cell wall galactomannan called MP1P, which is abundantly secreted during infection, is highly immunogenic, and is a virulence factor for Taloromyces marnifei. So it's a good immunodiagnostic target. Like the 4D1, it's consistently shown very high specificity, but the sensitivity has been variable. So this the NP1P EIA has been quite extensively evaluated across China and Vietnam. But what we're seeing is consistently lower sensitivity in China and northern Vietnam compared to southern Vietnam. And we think that that represents the phylogenetic clades of Thaloromyces monophei being similar in China and northern Vietnam, and then separate clades being prominent in southern Vietnam. So we think that the performance of this assay is clade specific. An exciting advancement was the availability of a commercial NP1P assay developed by One Thai Diagnostics in China. Our study last year in PLOS NTD compared the diagnostic performance of the commercial assay to our extensively validated in-house assay and found very similar performance. But the major advantage of the One Thai assay is that it's commercial, so it can be readily available for purchase, which is great for widening access. But also it uses a less time and labor intensive protocol and cuts down the turnaround time from 6 to 2 hours with a more automated and less labor intensive protocol. Currently, it's only available for purchase in China, and I think that availability unfortunately has been intermittent, but it's definitely a first important step, like the first commercial antigen test for thaloromycosis. Another exciting advancement is that another diagnostics company called IMI developed the NP1P assay into a lateral flow test. So this is a point of care test that can be performed in 15 minutes. It's very inexpensive. You don't need electricity, so it can be done in both hospital and community settings. Our study published earlier this year did a retrospective evaluation of the lateral flow assay in about 400 people with suspected thaloromycosis. What we found is that the LFA performs better in urine than plasma, interestingly. So the sensitivity in urine was 95% compared to about 89% in plasma. So our recommended specimen type would be urine. We found comparable clinical performance of the LFA and the EIA, and both were substantially more sensitive than blood culture, which had a sensitivity of about 78% in this cohort. We then took that forward to a prospective cohort, validation cohort of 900 inpatients with advanced HIV disease and any symptoms. So this is the cohort that I discussed previously. We compared the diagnostic performance of the LFA to the standard of care, which is blood culture and culture of other clinical specimens. But we also did secondary comparators of the EIA and then selective fungal mycobacterial blood culture, which is a special type of blood culture that's incubated for 42 days and increases the yield compared to conventional aerobic blood culture. Our major findings were, again, that the LFA performs better in urine, and it performs very similarly to the EIA. As expected, the sensitivity was better in participants from southern Vietnam compared to northern Vietnam, because we know that this antigen is clade specific. But overall, the LFA increased both the speed and the diagnostic yield over standard blood culture, identifying an additional 12%, 17 additional cases, correlating to an increased 12% yield compared to standard methods alone. And interestingly, the selective fungal blood culture increased the yield even higher, so 21%. But obviously, the turnaround time for that is very prolonged. The overall sensitivity was definitely lower than in previous cohorts, and we felt that this probably reflects its use as a screening tool, as well as picking up kind of lower sensitivity in the northern clade. So clearly there's some promising point of care diagnostic tests emerging for tularemycosis. And the next step is really thinking about how we can integrate this into clinical practice. So the first thing you have to think about when you're thinking about how to apply a diagnostic test is that the performance of your test is going to be highly dependent on the pre-test probability. So in the highly endemic setting of Vietnam, in our cohort of patients with advanced HIV disease, there was a prevalence, aka pre-test probability, of 19%. So when we looked at the performance of the LFA specifically in this cohort, if you take a patient who's got a negative LFA, that actually gives a 97% probability to rule out tularemycosis. And in this case, the patient probably does not need empirical treatment, although you should continue to pursue the conventional workup of standard culture. If the patient has a positive LFA, it gives an 83% probability to rule in tularemycosis. And in that case, we recommend considering starting empirical treatment while awaiting confirmation with definitive culture results. We don't recommend that the LFA replace conventional diagnostics, but rather like works alongside them. And actually all patients with advanced HIV disease should receive the standard of care, blood culture, culture of other clinical specimens, as that will serve to confirm the LFA result and also detect other pathogens. Any patients who've got evidence of a reticuloendothelial syndrome should also have a selective fungal mycobacterial blood culture incubated for 42 days, as well as alongside point of care diagnostics for other opportunistic infections which present with a reticuloendothelial syndrome. So the histoplasma LFA or EIA for histoplasmosis, as well as the urine LAM for TB and NTM infections. The WHO recommends screening for TB and cryptococcosis in a package of care for advanced HIV disease, but invasive mycoses endemic to South and Southeast Asia are left out of the picture. And I think that's kind of historically been because of a lack of diagnostic and data on burden of disease to inform the WHO policy. But with the huge advances made in diagnostics for tularemycosis, I think now really is the time to advocate for integration of point of care testing for tularemycosis and histoplasmosis within this package of care. From case studies, we know that MP1P antigenemia precedes blood culture positivity by up to 16 weeks. But what we don't know yet is really the natural history of antigenemia in the majority of patients with advanced HIV disease. And therefore, we don't know whether a screen and treat strategy for asymptomatic antigenemia would have a mortality benefit in tularemycosis, similar to how the cryptococcal antigen test is used in cryptococcal meningitis. In the final part of my talk now, I'll move to discuss treatment. So I was very lucky to spend several months in Vietnam last year and gain some clinical experience of tularemycosis. And there were two things that struck me. So firstly, the extremely limited and toxic treatment options for this disease. And secondly, the very high prevalence of co-infections, particularly with tuberculosis, yet a lack of guidance for how to manage these patients. The current treatment of tularemycosis relies primarily on just two drugs, amphotericin deoxycholate for induction therapy, followed by at least 12 months of itraconazole until immune reconstitution, so a really long course. And this recommendation is based on the IVAP trial. I think it gives you an idea of how neglected this disease is. There's only been a single clinical trial ever done for tularemycosis. And what it showed is that amphotericin deoxycholate is potent against Tallaromyces marniferae, but causes substantial toxicity, with over half of participants experiencing grade 3 or 4 adverse events, primarily myelosuppression and nephrotoxicity. On the other hand, itraconazole, while better tolerated, has reduced fungicidal activity, and numerous drug interactions, most importantly with the anti-tuberculosis drug rifampicin and similar drugs in that class, and that poses a major challenge for the patients with co-infection. I thought this study in another dimorphic fungal disease, so paracoxy, was really interesting. It looked at it's treated in a very similar way to talaromycosis, in that you give itraconazole consolidation for a really prolonged course. And what they found was when they took drug levels from their patients, over half of them had subtherapeutic itraconazole levels, and nearly a quarter of them had completely undetectable levels. I think that really demonstrates what a tricky drug itraconazole is in terms of its absorption, and really, we should be doing therapeutic drug monitoring for all of these patients. But even like in the UK setting, I know myself that turnaround times and availability of therapeutic drug monitoring is extremely poor. So how can we improve the treatment of talaromycosis? Well, I think there are certainly lessons that we can learn from other fungal diseases in the way of antifungal combination therapy. So this was an in vitro study published I think earlier this year, which demonstrated synergy between amphotericin B and flucytosine, which is another antifungal which has been used in combination to treat cryptococcal meningitis. And we know from the trials of cryptococcal meningitis that this is a safe combination to use. And they're the trials that have demonstrated that. So enter the LAMFAST clinical trial. This will be a 2x2 factorial randomized control trial evaluating a different formulation of amphotericin given as a single high-dose liposomal infusion compared to the standard 14 days of amphotericin deoxycholate, with or without the addition of flucytosine. And this trial has been funded by the NIH and is due to open for recruitment later this year. The second aspect of this trial is will evaluate the duration of maintenance therapy. So currently it's advised that itraconazole is continued until immune reconstitution, which can take anywhere from upwards of 6 to 12 months or more. And this arm of the trial will look at whether viral load versus CD4 guided cessation of itraconazole to see if it can be stopped earlier. I was also really excited to see that this phase 2 trial was recently funded in China. This trial will also evaluate single high-dose liposomal amphotericin versus the standard 14 days of deoxycholate, and will combine it with early initiation of ART within 7 days. So it represents the first trial to explore timing of ART in talaromycosis. I'm really excited to hear the results of this one. Just moving to my last slide. So for several decades, the treatment of invasive fungal diseases has been limited to just 4 major drug classes. And out of these, echinocandins have very poor in vitro activity against Talaromyces marnifae. You can see in the red here. With the exception of fluconazole, the azoles generally have low MICs. Flucytosine has kind of similar low MIC. But what's really interesting is in vitro data is now emerging for some of the novel antifungal compounds, and it's a really exciting time in medical mycology with these agents becoming available and seeing their efficacy in other invasive fungal diseases and thinking about how that might be applied to talaromycosis. Of particular interest is olorifim, which has very low MICs against talaromyces, and it also has kind of very favorable toxicity profile and extensive tissue distribution, so potentially could be useful as a consolidation therapy. The other drug I wanted to highlight was oteseconazole, which also has consistently low MICs and a very long half-life of 138 days. So, and a very favorable safety profile. So again, potentially a candidate for consolidation therapy. So in summary, this is a historically neglected fungal disease with a poorly defined epidemiology, which has probably gone kind of unnoticed and undiagnosed for several decades due to the reliance on insensitive and protracted culture methods. The mortality has been persistently high, and that's because of the treatment limited to just 2 drugs, as well as diagnostic delays. In terms of major advances, we've seen great progress has been made with the development of rapid diagnostics. And in terms of treatment, we've got some upcoming clinical trials, which hopefully will shape the future of tularemycosis treatment and make progress towards reducing the mortality from this disease. Finally, in terms of future research needs, I think there should be a multi-country head-to-head evaluation of antigen tests to understand how they work across Southeast Asia. We need to broaden access to diagnostics, and I think commercial options is part of that. Trials of the novel antifungals and antifungal combinations, and eventually a trial of screen and treat asymptomatic antigenemia. I'll just finish by acknowledging the fantastic network of tularemycosis researchers across South and Southeast Asia, as well as partners in the US at Duke University and in the UK. Thank you very much for your attention, and I'll stop sharing.
Thank you. Thank you, Dr. Brown. I'm glad to know I was wrong, that you are not in a different time zone. So it's good that we haven't been too much of a stress to you. We can take questions now. Sharon, back to you.
Okay, thanks, Hock. So we had some questions in the chat, and I've got a couple as well. But let's go to the chat first. And this one is for Dr. Krasaewes, and it's to do with autoantibodies and how you would investigate a person that's suspected of having this syndrome. What tests would you do? And is there just one test, or is there a whole suite of tests?
Thank you for the questions. So I would say the first clue that we can suspect this disease in the patient is that patient present with the T cell defect, opportunistic infection. For example, like in this the Syriac Thailand case. So this patient came with the NTM and also Thalomyces benefiae. All of this pathogen is a typical pathogen, which is an opportunistic infection. So we're not going to see this kind of infection in normal hosts. That is the first thing that we have to search more about the host status of that patient. So, and then we have to think which host status should defect going to be. Like this case is going to be T cell defect, because all the pathogen is like intercellular pathogen and also associated with the phagocyte. So that point us to the T cell defect in that patient first. And then I think the most common T cell defect, as we know, is going to be HIV infection. We have to rule out the host with the HIV infections first. And then if the HIV infection is negative, we can look more at the disease, other host status. In this case, so because Thailand also like a very endemic area of the Thalomyces benefiae, and also we have a lot of the patient with autointerferon gamma autoantibodies. So that's why we think about this disease when the HIV is a negative. So we send the further lab to confirm this disease. In my setting, we send the ELISA test for the anti-interferon gamma autoantibodies. Maybe same with the Syriac as well. I think so.
Mm-hmm. Are there any other autoantibodies that we should be looking out for?
Actually, they in T cell immune defect. In my setting in Thailand, we can send only HIV, anti-HIV, anti-interferon gamma autoantibodies, and the amount of the T cell count and only T cell count we can send. So we can send only this thing. If you ask about the something like an innate defect from the child, that's maybe genetic disease, we cannot send that kind of lab in here.
Okay. All right. I will continue with a question for Lottie. Lottie, one of the attendees would like to know about oral nanocrystal amphotericin against Talleromyces.
Yeah, that's a great suggestion. I think it's shown promise in cryptococcal meningitis with less toxicity than the intravenous formulation. So it could be an excellent option for Talleromycosis, but has not been looked at so far.
Okay. Before I hand over to Van Hock, I had a question for you. We occasionally get asked to do susceptibility testing for Talleromyces. We don't see this very often in Australia. Perhaps that's a good thing. What is your advice for labs that get asked to do susceptibility testing? And do you use the yeast phase or the mold phase? And what about the safety aspects?
Yeah, it's some great points there. I suppose the yeast versus the mold phase, they do have different MICs. If you look at there's some studies which compare yeast versus mold MICs, and that you can see sometimes quite big discrepancies between the two. I'm not sure if there's kind of specific guidance, but logically you would think about the yeast phase being more important because that's what's pathogenic to humans. But maybe both. I mean, if there isn't any guidance. And then in terms of the safety considerations, yeah, I mean, you need to have a lab that's going to have kind of category 3 classification in order to safely handle cultures of this fungus. Although, you know, in most immunocompetent people, it doesn't typically cause severe infection. You know, we should still kind of take precautions. It's still somewhat of a little bit unknown.
Okay, thank you. And thanks for a great talk. And also, Dr. Kawisara, thank you for your great talk. Van Hock, over to you to...
Thanks. Thank you, Sharon. I noticed that Dr. Miti Kulkari from Siraj Maidol University has joined us here. I want to say thank you to him for helping us pull this webinar together. It was his idea to get Dr. Krasaewes and Dr. Brown. And since he's here, well, anybody can answer this, either any of the Thai speakers, I think. When you have, this is from Thuan Tong, when you have a patient who has a T-cell mediated opportunistic infection and also has anti-interferon gamma antibody syndrome, do you do anything about the antibody? Dr. Krasaewes or Vongsakorn or Miti?
Can you repeat that again about the you mean the
Yeah,
antibody?
you treat the antibody syndrome, you treat the anti-interferon gamma antibodies.
Oh, I mean, in my setting right now, we treat with the opportunistic infection in those patients first, which is take time more than like 1 or 2 years to complete the all cause. But actually right now, because that disease is a kind of autoimmune something, so we have like a treatment option, for example, anti-CD20 rituximab for some patients. But in my setting, which is in Chiang Mai, we just start to try that medication on some patient who has a recurrent opportunistic infection, but we didn't do like a RCT try or something like that. We have like just observation. My
In this point, I can share something with my colleagues. It's a publication of using the bortezomib published in the CID, but it doesn't working well. And also there's another ongoing trial in our institution by Dr. Nasikan using azathioprine to treat the interferon gamma autoantibody body, but the result is still pending.
Okay. Thank you very much. You meant bortezomib, is it? Velcade.
But it doesn't show the positive result for the
Oh, okay,
bortezomib.
okay, yeah, thank you. If not, then I think we are on time. Thank you very much for a great webinar to everyone who's participated. Dr. Vongsakorn for choosing and presenting such a great case. Our three discussants, Dr. Atul Patel, Natalie Brown, and Thuan Tong Tan for their insightful questions. And of course, to Dr. Krasaewes and Brown for very comprehensive and enlightening presentations. There should be some portal for feedback, right? Where's the secretary? Yes, please complete the feedback survey. And thank you very much once again, also to the audience for listening in. I just want to advertise our upcoming conference in Kuala Lumpur. It's called ISHAM Asia, so shouldn't be very far for all of you in the region. We have a course on the first day, on the 9th of September, and then a conference proper from the 10th to the 12th. So thank you very much, and have a good evening, everybody.
Thanks from me as well, and terrific to see you. And the next webinar will be, I think, sometime in August, and we hope to run an equally stimulating session. Thank you.
Thank you so much.
Bye-bye.
Thank you. Bye-bye. Good evening.
Thank you to all of you. Thank you, Vongsakorn. Thanks, Sharon.
Thank you, everyone. Bye.
Yeah, thanks, Miti. Thank you very much, Miti. Thanks, Thuan Tong. And thank you very much, Pravi.
Thanks, Prof. Tan.